Well, thanks. So yeah, just to say welcome everybody. This is amazing. It's really lovely that so many people have turned up in their lunch hour, often on a busy day, especially if you've got work on as well or grandchildren in the background. So really appreciate you all coming. So we're really chuffed because we've got Dr. Scott Murray, Consultant Cardiologist, has joined us today. Because a lot of the people who we speak to, either patients or professionals, sometimes have a concern about if we're eating a low carbohydrate diet, does that mean that we're going to actually be increasing our fat intake to a point that might be dangerous from a cardiovascular point of view? So we're hoping we're going to hear some good insights about that from Scott in a little bit. So before we move on to that though, because some of you have been before, but some of you haven't, so Gail's going to do a little recap on why we're recommending the low carbohydrate approach. So I'm going to hand over to Gail to do that in a minute, and then we're going to hear from Scott for about 15 minutes, I think, and then we're going to have about 15 minutes Q&A, and then we'll let you know what's happening in upcoming events. So 6 minutes past, Gail, what do you think? Do you want to go for it?
Yeah, that's great. So welcome everyone. We've had great sign up today, from hospital consultants to trainee practice nurses to medical students. So hopefully there's something for everyone. There's a few reasons why Ruth and I have started these educational webinars. Firstly, we've both really struggled to find access to study days around remission for type 2 diabetes and how to improve diabetes via lifestyle. But it's also to upskill and help support those healthcare professionals that want to know more. So we know type 2 diabetes can be reversed and many people can place it into remission. So it's important that we let these patients know so they've got balanced choices for their treatment options. So we acknowledge low carb is not the only way to achieve this. There's bariatric surgery, very low calorie diet, low calorie shakes. But personally, we've been both having amazing results using low carb with our patients. We're on a network of hundreds and hundreds of healthcare professionals also having amazing results. And there's really good evidence to support this. I'm just going to read the 2020 ADA guidelines. Reducing overall carbohydrate intake for individuals with diabetes has demonstrated the most evidence for improving glycemia and may be applied to a variety of eating patterns that meet individual needs. It's also tucked away in NICE 2017 1.1.3 and Expert 2020 position statement supports low carb as an option. So just a quick recap on low carb for those that missed our first training session and people that are really new to it. Apologies if you're already upskilled on this, but we're going to do this every session just so everyone's. So this is today. Ruth's already mentioned, Scott's kindly agreed to give up an hour of his time. That was the other thing we wanted to mention. This is an unsponsored, these webinars are unsponsored, and it's done in our own time and the speaker's own time. So just need to sort of make that clear. So I've shamelessly stolen this off Dr. David Unwin. If you have type 2 diabetes, sugar becomes a metabolic poison. And it's really helpful to ask patients where they think the sugar's coming from in their diet. If you have someone who's got a really obviously sweet tooth and adds sugar to everything, you know, cutting that out is really obvious information and advice to give them. But if they've already done this and their diabetes is, you know, is still there, or they still want to make improvements, teaching them where else it might be coming from is really helpful. So starch is chains of glucose holding hands. These break back down to individual glucose molecules, you know, when you eat them, so rapidly raising blood glucose. We love these sugar infographics that David Unwin has produced. They're quite good visual aids for patients to see how food might affect their blood glucose. For example, a banana may affect their blood sugar the same as 5.7 teaspoons of sugar. And that's going to be different for everybody. Everybody's blood sugar will respond differently to that banana. So what can patients eat? This is about lower than what they would normally eat. Any reduction is going to have an effect on their glycemic control. It has to be personalized, it has to be for the patient. They all have different starting points. Eat the meter, I really like that. You know, eating foods that don't massively spike blood glucose, keeping a nice, you know, good flat line, a steady blood glucose control, eating real food, like the picture there says. You know, this blood glucose is nice and steady, it's within the normal range, and that in turn is going to turn down insulin requirements, keep insulin low, and, you know, particularly for patients that already have insulin resistance or weight issues, that's really helpful. I just want to show a graph of a patient of mine I've been seeing during lockdown. So this was the first lockdown, June last year. You can see she had an HbA of 118 millimoles, so really high. She has done this in 5 months using a low carbohydrate approach, and she's done some time restricted eating. So she's lost 45 kilos to date, and that's an incredible HbA1c drop. She was initially on metformin, but it's not taking anything for it now. Ruth made me put her cholesterol readings in as well, just to make it relevant for today. So good improvement in her cholesterol profile as well, even though she's definitely probably eating more natural fats. So she's reduced her HbA1c by 89 millimoles. Now, I came across this tweet this week, actually, from a cardiologist that's going to speak to us. So I didn't realise that every 10 millimole drop in HbA1c, there's a 10 to 15% reduction, which is amazing. So my maths is dreadful, but that's at least an 89% drop in her CVD risk, if that's a linear calculation. I'm not sure, maybe Scott can clarify that. So yeah, Reese's going to introduce him. I'll stop sharing my screen now.
Brilliant, thanks Gail. So just as Gail said, thank you so much to Dr. Scott Murray for joining us, because he's an incredibly busy man, has given up his time completely for free for us, so we're really grateful. So just by way of an introduction, so Scott's a consultant cardiologist, clinical lead for cardiology at the Wirral University Teaching Hospital, past president of the British Association for Cardiovascular Prevention and Rehabilitation, honorary senior lecturer at Liverpool Centre for Cardiovascular Science, University of Liverpool. So after medical school in Glasgow and training in cardiology in Liverpool, as a consultant interventional cardiologist, Scott became disillusioned with the inverse focus of cardiology. Despite his love for intravascular imaging gained during his thesis, he decided to give up his stent habit to focus on CVD prevention and cardiac CT. He's been involved in comprehensive CVD prevention and rehabilitation strategies, both locally and nationally. And as you've seen, he's quite happy to talk about it on Twitter, which is sort of where some of us came across him. And honestly, when you see his tweets, you're there going, so why are we not all doing this? So without any further ado, I'd like to hand over to Dr. Scott Murray.
Thanks very much, Ruth. Thanks for having me on this incredibly busy webinar. It's great to see so many people starting to get involved in this. So I'll be quick. Let me just share my screen and get to my presentation. If I can. So this is, can you all see that? Okay.
Yeah.
So this is a talk I gave as part of Fixing Dad. There was a global sort of feature, Fixing Dad. So if anyone hasn't seen Fixing Dad, I'd recommend you go and look at that, because it's a great movie about two sons who spent a few months off their work just helping to heal their dad from his diabetes. It's really inspiring. So that's why I work with these guys. So a few years ago, we did a comprehensive cardiovascular prevention strategy for Liverpool. And this is the global burden of disease study for Northwest England as to why we die from cardiovascular disease. And you can see that high blood pressure, dietary risks, and high total cholesterol feature in the top 3 as to why people suffer. So let's get into the nitty-gritty. So a lot of people come with a family history of cardiovascular disease and a family history of bad lipids. And often that can be genetic, but it can very often be environmental and very much sort of family cues and habit that are involved in this. And I would say that the majority of this is actually preventable. There was a study done by Salim Youssef in 2004, published in The Lancet, and he's an ex-president of the World Heart Federation, called InterHeart. Now, this looked around the globe at why people were having myocardial infarctions, and they narrowed it down to 9 main risk factors that accounted for about 90% of the population attributable risk of MI. And you see this thing here, abnormal lipids. Let's dive a bit deeper into that. So 80 to 90% preventable, I think, most of myocardial infarctions. And you see the highest risk factor here adjusted for all is the ApoB over ApoA1 ratio. Now, this isn't LDL cholesterol or total cholesterol. This is the total amount of your bad lipoproteins in your system divided by the total amount of your good lipoproteins. So B being, if you just remember it as bad, then that's probably the easiest way to do it. So let's look at that. Why is that? But you can see it's a linear relationship in terms of odds ratios. The higher your ApoB1 over ApoA, the more likely you are to have a heart attack. Just as a little segue, there is a study looking at lipid markers in people who are deemed to be insulin sensitive or insulin resistant. And you can see here, if you look across this is for females and males. If you look across here, ApoB substantially different, HDL-C substantially, everything in this is actually substantially different, including blood pressure, waist circumference, BMI, fasting glucose, fasting insulin, triglycerides, total cholesterol, and that stands the same for men and women. So why is this important? From these two papers, your risk of heart disease increases as your ApoB over ApoA1, or as a surrogate measure, your total over HDL, or non-HDL, as we sometimes measure these days on non-fasted lipids, compared to your LDL in terms of your risk of developing heart disease. And in actual fact, the increasing ApoB over ApoA1 ratio is really just a surrogate of insulin resistance. So we're seeing here the link between these markers and the person at the end of the blood tests. So I want to, if anyone is interested in a deep dive in this, if you go to PACE CME, which is available free on the web, this chap here is Professor Borge Nordestgaard, who's done a lot of work in lipids, particularly in familial hyperlipidemia, but generally just one of those legendary figures, a bit like Thomas Dayspring, who's been involved in lipids right from the beginning. And this is a recent paper published in JACC, which is a big cardiology journal, from the Copenhagen General Population Study in 109,000 individuals, saying that in actual fact, we should be concentrating our lipid focus and our interest on ApoB containing lipoproteins, and particular VLDL cholesterol. So let me just explain a little bit this, because it's quite detailed and I want you to try and get some take homes. So they say here that the ApoB containing lipoprotein, which is the main ApoB coming from being produced by your liver, ApoB 100, 50% of the risk comes from the VLDL cholesterol component, 29% from intermediate density lipoprotein and LDL cholesterol, but nothing from VLDL triglycerides. And if we look at the likely mechanism, these are all your ApoB containing lipoproteins. The VLDL component, which is composed of both triglycerides and cholesterol packaged up in a lipoprotein, if that happens to get into the intima, it is directly scavenged up by the macrophage, which then goes on to create the foam cell, which is where the atherosclerotic lesion comes from. If IDL or LDL get into the intima, then they can be taken up by the macrophage, but they often have to be modified. So have to be oxidated or glycated in order for that to be sort of scavenged up. And if we look at the data from this study, we see that actually VLDL cholesterol has a hazard ratio of 2. IDL cholesterol has a hazard ratio of 5. But LDL cholesterol on its own only has a hazard ratio of 1.86. So VLDL cholesterol explained 50% of the MI risk from elevated ApoB containing lipoproteins. And then IDL and LDL together accounted for 29% of the risk. And the study included 25,000 people who were free of lipid-lowering therapy at that time. And that's obviously a difficult thing because a lot of people are already on statins here. Just to go a wee bit deeper into this, this is the source of your cholesterol remnants. So what's left over, and you see that HDL and LDL don't have a lot of triglyceride left in them. So your source of your cholesterol remnants tends to be intermediate density lipoprotein, VLDL, and chylomicrons, which are coming from your gut-derived lipid. So there's a cat trying to get in on this talk here. Go away. So it's very important that your liver stays healthy because that's the only way to really reuptake these cholesterol containing particles. And also to make sure on this end that you're actually able to uptake fatty acids at the tissue level, because that's what helps you to clear these remnant cholesterols. And down here you can see that the best thing would be to have a low LDL and to have low remnants, because that doesn't affect things. But in actual fact, if your LDL is low, but your remnant cholesterol is high, then you're at the worst risk. So it's just to try and explain that there are a lot of nuances in here to this. It's not black and white, good and bad cholesterol. And I think plenty of people have heard me saying this in the past, that we've oversimplified this. So for you guys, how do you calculate remnant cholesterol in a clinic? It's actually quite easy. You just take the total cholesterol and you take away the LDL and the HDL. And what you're left with there is the remnant cholesterol, which is, an important measure. If this is done on a fasted lipid profile, then what you're seeing there is how much VLDL cholesterol and how much IDL cholesterol is left over. If you do it on a non-fasted and someone's just had a pint of cream, then you're going to see a lot of chylomicron remnants left there, and that will affect the interpretation here. So I'll move on quickly. But what we must state here is that the actual life cycle of these lipids in the bloodstream is different. So VLDL's job is actually to take all that lipoprotein and try and find a place that needs it. So float around in the bloodstream, go to the muscles, the adipose tissue, any cell in the body that is needing fatty acids for for fuel, and to drop that off. And it tends to try and do all that within an hour of it being packaged out of the liver. Then you've got IDL cholesterol, which doesn't really hang around in the circulation for long. And then you've got LDL, which sits around for 2 to 4 days. So the LDL is still important, because if that LDL is modified or oxidized or glycated, it's still going to be an issue. And obviously the lifetime exposure to these cholesterol particles is what obviously drives a lot of cardiovascular disease. But I want you to just think about this, in that this is what would happen in an optimum system. And in people who have insulin resistance in the liver, in the muscles, in adipose tissue, they ain't taking any of this up. And that's where the problem comes. If you're energy toxic, you've exceeded your personal fat threshold, and you've got nowhere to put stuff, it all comes back into the bloodstream. So you've now got non-esterified fatty acids spilling back into the blood, going back to the liver, bound to albumin, to then be repackaged as new VLDL particles. And so the cycle continues. So what we need to do is find a way to reduce the amount of triglyceride containing lipoproteins we produce in the liver, and increase the disposal of that. And that's why diet and exercise works so well. So here's a schematic, and I'll make these slides available to everyone because obviously I'm going quite quickly here. But this is the basic tenet of what is happening within your body. And this is where we need the liver and the peripheral tissues to really be working well. So we don't control cardiovascular risk factors very well. Blood pressure, dyslipidemia, diabetes, obesity, badly controlled. Often pills help us, but sometimes that's not the solution, as you can see by the bottom parts of these graphs showing actually what the control was in the end. And I think a lot of this is down to hyperinsulinemia and insulin resistance in the basic tissue, at the basic tissue level. And this was shown in 1996 that hyperinsulinemia was an independent risk factor for heart disease. But we didn't really pay any attention to that because at that point we had a brand new drug which could control the level of your LDL cholesterol. So here are pictures of hearts. One is healthy on the left and one is unhealthy. And I say it's healthy, but I've said before it's not healthy because it's on a slab. But this was a person who unfortunately died of a non-heart related condition, and their heart was cut out and it looked particularly healthy. This is a patient of mine who agreed to have his picture taken, but this is what you should be looking for in terms of patients who are clearly insulin resistant, so waist to height ratio not great. And actually the tummy is quite hard to touch. It's not a soft flobby tummy. It's packed. The adipocytes are packed full. And this chap's echo showed diastolic dysfunction, mitral regurgitation, and a global layer of adipose tissue seen. So if you can't store fat any further in your subcutaneous depots, it goes to the heart, the liver, the pancreas, creates a problem. And this is this chap's CT scan. So you can see the amount of fat that's around his heart, actually sort of encasing his heart and making it difficult for it to relax. And this is this chap's left main stem. You can see that at the actual start of his left main stem here, he has a mixed calcified plaque, which is taking up not quite half of the space of the blood vessel. Blood is still flowing down this part, but it's clearly a risk factor for developing cardiovascular disease. So I would say stop eating crap is what I call it, because the combination of the carbohydrate component and the fat component is what is driving up these lipids. It's energy dense, so we're becoming energy toxic. This is one paper which shows that in order to keep your liver healthy, you need to actually probably decrease carbohydrates and fat consumption. High carbohydrate diets increase liver fat by strongly stimulating de novo lipogenesis. So you're making fat in the liver. Dietary fat retention is difficult to get away from. And this non-esterified fatty acid uptake is what I spoke about, things spilling back into the blood from peripheral tissues. This is research work we've got ongoing in Liverpool looking at epicardial adipose tissue, volume and density, and the corresponding coronary artery disease that comes with that. And that's because we think that coronary artery disease is not just about cholesterol. It's about this whole pathway where positive caloric balance and unhealthy nutrition combined with sedentary lifestyle leads you to adipocyte hypertrophy and lipotoxicity as well as glucotoxicity. And that's a vicious cycle where you create direct pathogenic effects which eventually fur up your blood vessels and make your heart fatty. Non-alcoholic fatty liver disease is one of these pathological consequences of this. And we can see here that in actual fact, all of these steps around fatty liver are related to insulin resistance, endothelial dysfunction, altered lipid metabolism. But you see around the outside that encompassing this, there's a whole load of inflammation, plaque formation, oxidative stress, insulin resistance, endothelial markers, and increasing plasma-free fatty acid levels, liver fat content. So we want to get to a point where we're able to recognize this in people here, rather than recognizing it where we do at the moment, which is when people develop symptoms. And hopefully, if we get in earlier here with education on lifestyles and traditional risk factors, then we can impact on this greatly. And it's all about keeping the blood vessel healthy, particularly this perivascular adipose tissue, because if that gets overcrowded because of laying down fat on your heart, then that is a way to signal to the vessel that there is an inflammation and unhappiness. And then you start to trap lipoproteins that are present in the blood. So I would say that insulin resistance, hyperinsulinemia, and impaired insulin action and clearance is at the root of a lot of this. and that is what is driving the problem with cholesterol. That's what's driving the problem with glucose. Glucolipotoxicity is a serious issue, and it's all coming from energy toxicity. How do we recognize these people? I've gone into that a little bit. Waist circumference to height as a sign that you're overfilling your adipocytes. How do we minimize it? You maximize the nutrient density of food. You minimize the glycemic impact. You keep insulin pulsatile because it switches your cholesterol production in the liver on and off. If it's too high, it will keep cholesterol production on. So you'll make more ApoB, VLDL, like I've explained earlier. And we want to make sure that that is optimized, or else it is the statin pill to try and keep that under wraps. I'll skip through this because I know we're tight for time, but if you measure glucose metabolism in patients with heart attacks after the heart attack, you find that in actual fact, 1/3 say they're diabetic, but really 2/3 are diabetic. And 72% of people are actually dysglycemic. So that's why lowering carbohydrates to get more time in range is very important. And you can do this in 2 weeks. This is evidence from a Freestyle Libre of someone who had 0% time in target, and over a period of 2 weeks got to 100% time in target in 14 days just by eating to the meter, as Gail said. But you can't ignore exercise. It comes part and parcel of it in order to improve all the aspects of what I've been talking about. So I'll wrap this up. Here are my, I love alliterations. So here are my, I've done this before as well on a previous talk, but I've updated it. Here are my Scotty's several sins sending sickness sometime soon. So there's sugar, sugar sweetened beverages, smoking, saturated fat from processed sources, buns, biscuits, cakes. Let's get that clear. Sitting, sedation, sarcopenia, so lack of muscle mass and not moving enough. Slothliness goes, hand in hand. Sick fat, so adiposopathy in your heart, your pancreas, your liver, expanded your subcutaneous adipose depots till they're bursting. Substantial starch in cereal, I've spelt cereal wrong, sorry about that, but that doesn't always help. A sandwich subculture, so meal deals, crisps, sugar beverages, free cookies, etc. Snacking between meals, salad dodging, one of my favourite pastimes being a Glaswegian. Stress, sleep deprivation, sexual dysfunction. If anyone presents with erectile dysfunction, that predates a myocardial infarction by 3 years. Solitude and sadness and suffering, all not great things for your heart. So thanks very much for time. I'm happy to answer any questions now.
Thank you so much.
That was okay.
Yeah, that's amazing. Wow, thank you.
Bit of a whistle stop tour. Sorry it was so quick.
I think it's whetted our whistles though. I've seen you a few times on YouTube and stuff, so I'd really encourage anyone to go and have a look at some of Scott's other lectures where he goes into this in more detail. They're really, really fascinating.
A few people were asking if they should be testing fasted lipids only then in GP practices, because a lot of them are done not fasted.
I don't think it really matters. As it's not really that practical. It would be good, but actually the lipid guidelines say not to do it now, to do it just unfasted and look at non-HDL, because that is a better marker of your total ApoB lipoproteins in a way. So there's various cheats here. One is to just do it non-fasted and look at non-HDL, which would give you a bit more like what we discussed in ApoB over ApoA ratio, or total ApoB. But until we move to actually completely measuring total ApoB and total ApoA, I think we're just left with what we've got. It's quite expensive, and a lot of the lipid stuff is expensive. For what benefit? I mean, if it's abnormal, you just tell the patient to get their lifestyle in order, and if they can't, they're going to need to take medications, of which there is a vast array nowadays.
Someone's asking what you think about CAC scores. Should we be doing these more?
I think we should, and the reason for that is that if someone's at a risk level where you're thinking about giving them a statin, The only way really to tell someone's real risk is to get a calcium score, because you can net reclassify about 40 to 50% of patients based upon their calcium score using MESA, which is a calculator, or AstroCharm, which is an online calculator that utilizes CAC score. And it is really good at reclassifying people, because you could have someone who comes out really high on a standard risk score, but they've got a calcium score of 0 and they're over 50, which puts their risk at less than 2%. And therefore, they wouldn't get a great deal of benefit from being on a statin.
What do you think about measuring insulin levels, Scott? It's not something that we can really generally do at the moment, but from what you just said, I'm wondering whether that would be much more helpful than lipid profiles.
Well, I mean, we've got it for a research study, but I think it's quite a noisy metric, and I think that's why it's been ignored for a while. I mean, you can go to HOMA IR and try and make it a bit more credible. That features in quite a bit of research work, but I think it's such a time-consuming and variable thing. If we all had enough time and everything at our disposal, then the best thing to do for people would be to do an oral glucose tolerance test, and to also measure their insulin levels to see what happens when they eat foods. But it's very time consuming and costly. I think from a general practice perspective, you're probably better just doing a waist to height and a look at the lipids and a fasting plasma glucose and an HbA1c, with a caveat that the HbA1c is just a mean look at what's happening over 3 months. And you have to think that within that mean, there'll be probably a lot of hyperglycemia, but probably a lot of sort of glycemia around the 3 to 4 level potentially, that basically evens it out. So I always say HbA1c is just regression to the mean, really. And it's not a great marker of whether someone has very high swinging glucose measures. That's why Libras are so good, because they show you what's happening.
So from what you're saying, then the damage to the lipoproteins or the endothelial glycocalyx, that can happen with swinging in blood sugar. So a normal-ish HbA1c in someone that's taken quite high doses of insulin for their type 2 or type 1 diabetes is not reassuring.
Yeah, I mean, I think delivering a lot of sugar into the bloodstream is bad on a number of levels, because it upsets your glycocalyx, more likely to glycate your lipoproteins. At the liver, at the level of the kidney, it's telling the kidney to express SGLT2, which then means that you save sodium. And when you save sodium into the bloodstream, the kidney thinks your blood pressure's dropped, so the kidney activates the renin-angiotensin system and puts your blood pressure up, and you retain fluid. So I think there are multiple reasons not to have a swinging blood glucose. And we're only meant to have 5 grams in there, so why would you eat things that have 50 grams of sugar in it, for instance? I mean, it's just madness.
You've just reminded me that sorry, I was going to say there were quite a few questions on SGLT2 inhibitors, and I know that you've written a paper recently about that. But I know certainly some renal physicians and endocrinologists as well are concerned about how we're deprescribing SGLT2 inhibitors, because we don't think we need them in people who are doing well with their low carb approach. But actually, should we be leaving people on them if it's going to be renal protective or cardioprotective? What do you think about that?
I think that the difficulty here is there is a treatment gap, and it's the same for statins. I think you have to be sure that that person is completely nailed down on the lifestyle, because we all have blips. I mean, I'm no saint, in terms of certainly alcohol consumption. That's my big thing, being a Scotsman. Something in my epigenetics means that I like beer. So I think there's that treatment gap, and we're going to try and do a pilot randomized trial of SGLT2 versus therapeutic carbohydrate restriction in pre-diabetics. Locally, we've just submitted, we're in the process of submitting for grants for that. And I think what will happen is the first 3 months they'll be equal, but then potentially as the dietary, some people who can't stick to dietary stuff start to slip, then the pill will provide that continually. And obviously the pill has the evidence behind it. It's got multiple randomized trials, whereas we're talking about evidence that is just in single specialist practices who happen to focus on this. And so there is a treatment gap, and I don't know the answer. I don't think anyone knows the answer yet.
Ian Lake's just asking, why is diabetes so far down the risk rankings when hyperinsulinemia is driving the LDL?
I think diabetes diagnosis in all clinical trials is actually under appreciated. Those are the people who, during a questionnaire being admitted to the trial, put their hand up and said they were diabetic, or their HbA1c was in a diabetic range. I think if you tested everyone for diabetes in situ with what I described, an oral glucose tolerance test with both measuring insulin and C-peptide and blood glucose, you'd find that probably, more than half of the population are diabetic at some, cellular level, especially people who are, Asian or from indigenous heritage. I think they tend to have wilder swings in blood glucose and also a lower capacity to store fat under the skin. So a greater chance of having visceral adiposity and hepatosteatosis, pancreatic steatosis, these things. So I think it's just underrepresented. And remember, it's not just LDL is a proxy marker of total ApoB lipoproteins, because they tend to move in the same direction on blood tests. But there is a bit of discordance between the two. So some people's LDL goes up, but their ApoB goes down. And I think we're only just starting to understand this as a concept, if that answers that question.
Thank you. Kathy wants to ask you a question.
Yeah,
Kathy, do you want to
so many questions and so many things. It's absolutely brilliant to hear this. Just the first thing is the idea that there are people who are diabetic but they don't know it. 21-year-old in our practice, slim lad, no body fat at all. He has one hot chocolate made according to the recommendations, blood sugars up over 11 immediately afterwards.
If he's thin, he could have maturity onset diabetes if he's young. Well,
yeah, well, he's not technically. This is just a game. We were just playing a game in the practice testing because he wanted to be tested. But that's an example. Colleagues, husband, BMI of 40, just got the 2-week free trial of Libra, is showing that he's swinging from diabetic range down to hypos effectively.
Yeah, that's what happens.
Explains his hunger. I think the Libra is the key. The Libra is the thing that's now giving people the concrete information to explain why they're getting what's happening is happening, particularly
Absolutely.
the hunger. So that's a convert. That GP colleague is now a convert to the low carb approach.
Yeah.
My question is, in general practice, we are bound by this quality outcomes framework in the UK. In England, I don't know what the Scottish others are. Quality outcome framework now just says if someone's got diabetes, they're on a statin. We don't look at the type of cholesterol. It's everybody's on a statin and you get paid if they're on it and you don't get paid if they're not. Are you aware of any conversations going on that are going to move us into a more sophisticated conversation about cholesterol?
So basically, QOF, I think, is probably going to die, but in the meantime, it's going to be audited by a thing called CVD Prevent, which has been launched by NHS England, but it keeps being put back, and that's an audit of primary care practices. So it's worth looking that up. NHS benchmarking are going to run that. Right. But the problem we've got with that, I'm on the National Cardiovascular Prevention Leadership Board, is that apart from people like Kaushik Ray, who's a big public health cardiology doctor down in London, who presented to that board, the driving paradigm is still LDL reduction. Absolutely. And just because it's what's in everyone's mindset, bad cholesterol, and let's get that down. And there are pros and cons to that. I think it simplifies the understanding of the underlying issues, but you have to sort of balance it up against what is going to give the best bang for buck. I think as we move forward, this, sort of, as you say, this awakening of normal people have massive swings in blood sugars, and that then is one of the catalysts for your liver potentially having to store extra energy and then becoming dysfunctional in terms of the main cholesterol production pathways. I think that when we look at cholesterol profiles now, we should be actually thinking to ourselves, what is driving this? Is this genetic FH? Which, if it is, you'd be looking at total cholesterols up sort of above 8, with LDL cholesterol certainly above 5 or 6. But in that sense, if the triglycerides are high and the person is obese, it can be like people I've had in my clinic where they're having 4 muffins for breakfast and then they're having 2 Chinese meals at night for the dinner. And that's why they've got triglycerides and cholesterol in the sky. So yeah, I think we're still at early days of convincing both people at the top that there is merit to this.
Can I just ask, so one more question? It's about low cholesterol. Again, I see people in their 80s and 90s who are being blitzed with statins, with cholesterols that are coming down to 2, total cholesterol down to 2. Now, I've read a paper that said that there was a J-shaped curve in terms of total mortality when you reduce cholesterol, i.e. you get below a certain point and then the number of deaths increase, all cause mortality. Are you aware of an adverse impact on people if you drop their cholesterols too low?
I think some of the jury on this, I know that paper you're talking about, and there are quite a lot of papers that are out there from people who are genuine cholesterol skeptics. And I think whilst a lot of their arguments have some senescence, I think it's hard to argue with the benefit in randomized controlled trials of statins in people who have genuine cardiovascular disease. They've got furring up of their arteries, they are metabolically unhealthy, they can't embrace lifestyle measures. If you've got someone who's elderly, who's getting muscle pains and turn down in their spark and vitality because they're on a statin, their cholesterol is exceptionally low, then I would say, if they don't have a previous heart attack, if they don't have a previous stroke, previous vascular disease, and they've just been put on it because of their age and their total cholesterol, I would be taking them off them to see what happens to their cholesterol metrics. Because what might happen is the cholesterol might just go back to what's normal for them. And when they're in their 80s, there are some papers to show that there's still some benefit, but I think it's got to be a shared decision at that stage, around what you think is right. There are no papers showing that cholesterol that's exceptionally low is exceptionally bad in terms of youngish patients. There's a lot of work showing that if you put people at high risk and you lower their LDL, that people are not dropping dead because of low LDL when they're young. They're more likely to be dropping dead of heart disease caused by high lipoproteins. Well, in one part, you have to remember that the whole cholesterol story is only one branch of a massive tree that leads to heart disease. So yeah, I would reevaluate those people, especially if they're not feeling right.
That's Tom Mallins has got a question. Tom Mallins has got a question that a few people want answering. Tom, do you want to unmute?
Yeah, hi. My question was, are there distinct pathways that influence HDL that could be leveraged by lifestyle measures? And are these pathways or are these changes different to that would impact LDL?
Yeah, so HDL and the whole ApoA1 story is an interesting one, because the pharmaceutical industry have tried for ages to create drugs that boost your HDL, and because HDL is so important in terms of your risk, I mean, actually doubling your HDL if it's low can have a better impact than lowering your LDL if it's high. And that's just purely because you know, HDL has got such a important job to do, pulling these cholesterols out of the tissues when they shouldn't be there. So in answer to your question, drugs that affect HDL don't work and have never worked, because often the drug does something else. It like puts blood pressure up or something, which is a bigger driver of heart disease. The best thing to do for HDL is to get people exercising and to get them to consume healthy fats. So fats which contain high omega-3 content, and also monounsaturated fatty acids. So this isn't chugging cream and frying fish in vegetable oil. This is, you know, pouring extra virgin olive oil or you know, extra virgin rapeseed oil on salads, and eating eggs and avocados and nuts and these sort of things, nuts and seeds, which not a lot of people really want to do, but that is the way to improve your HDL. Also, a little bit of alcohol, in particular red wine, is always a pleasing one for thinking that when you're drinking it, you're improving your HDL, which is what I tell myself anyway.
Well, glad to hear that.
But yeah, people's HDL goes up on a healthy high-fat diet. When I say healthy high fats, not chugging cream and you know, having a huge. I think it depends on where people go to for their sources of extra fat. I think that's important, because you don't want to be, like I said, chylomicron remnants and spiking your blood fats after every meal in a bad way is probably just as unhealthy as spiking your blood sugar in a way, but only if you've not got a way of clearing it. And that's the most important thing, is if you are, you know, a runner or a cyclist or something like that, and you're able to burn fats really well, and you've got high fat oxidation, and it might not be a problem for you. Similarly, if you're running on glucose and you've got really potent GLUT4 receptors, and you're able to churn that out and not have it hanging about in the circulation for long, then I don't think that's going to be that big an issue. So I think it's about metabolic flexibility here. And that's always what I think people should be aiming for. Be able to burn both, be able to burn glucose and get rid of it, be able to burn fat and get rid of it. Don't be stuck in either paradigm, which I do worry about with some people on keto diets, that they become glucose intolerant and down-regulate GLUT4. But in actual fact, you want both to be firing.
Thank you.
What do you think about people who are sort of retired athletes who've ended up developing sort of type 2 diabetes? I presume that was from years of sort of carb loading prior to races and things.
Possibly. I mean, there's almost you know, a genetic influence there, and if you maybe aren't doing as much as you used to do, but you're still consuming the same amount of things that you used to do when you were training, it may be that's an element there. You know, that's probably something you want to ask Tim Noakes, because he's the one who developed that, isn't he? He was the athlete who developed diabetes like his father.
Right. And the other thing I wanted to check was there was a recent paper, say recent, it wasn't that recent, maybe 6 months ago, where they said that there really wasn't any evidence for recommending people avoid saturated fat as it comes in sort of dairy, meat and dark chocolate, I think was on the list.
Yep. So there are.
You said about your cream comment, because I'm not telling my patients to guzzle down cream, but I'm telling them they don't need to avoid it as much as they
No,
might.
I wouldn't avoid it, but I'd just be mindful that if you are energy toxic at the base of this, and let's be clear, the reason why diabetes develops is that you're energy toxic, and removing the energy is what creates the space for you to process things. And there's plenty of people who've reversed their diabetes by using plant-based diets or low energy diets, or, you know, low, even upping their carbohydrate amount in their diet, but actually drastically decreasing their energy. As long as you're losing fat from your liver and fat from your adipocytes and fat from your muscles, and you're creating negative balance, and you're able to now put stuff in places where you couldn't, then your cholesterol will go down. Your, you know, your risk will go down. It's just about that time and range, I think, where low carb has the benefit. How do you get people's blood glucose more in range for longer periods of time? And that is one of the big wins. Also, going low carb helps you manage your triglycerides in your blood. So I think that those are the major boons that we've got from a low carb perspective. The reason why I say don't chug cream is that if you're energy toxic, cream's possibly the most energy potent thing you could eat. And I think it's okay if it's just to take away a hunger pang where you were going to eat a Mars bar or something like that, you know. But it's not for, you know, chugging at a regular basis. Other people will say different things. That's just my opinion.
Have you got time for one more question, Gary?
Yeah, I've got plenty
Kathy,
of time.
and oh, cool, thanks. Gary and Kate, I see that the latest meta-analysis of low carb diets show that a low carb diet increases LDL. Can you comment on this?
Yep. So I think if we get to the nuts and bolts of it, I think there is a deep, intricate relationship between LDL and glucose. And I genuinely think that if you start to decrease the total amount of glucose and glycogen and stores of glucose in the body, then there is a reciprocal increase in other energy sources in the body in terms of lipoproteins. Now, we know that SGLT2 inhibitors increase LDL, yeah? And that's because you are peeing out more sugar, you're stunting the abundance of glycogen in your body, and you're forcing the body to a more fat-burning paradigm. So I actually believe Dave from Cholesterol Code, Dave Keto, if anyone knows who he is, in the lipid, the main job of lipids in the body is actually transferring fatty acids as energy sources to tissues. And if you're changing your balance in this, then yes, your LDL will go up, but your HDL might go up as well. So your actual ratios will be the same. And what might happen is your total cholesterol might go down, as we've seen from Gail's example. And that's what happened in David Unwin's subjects that I was involved in. Total cholesterol goes down, and if HDL and LDL have gone up, that's great, because remnant cholesterol has then gone down, which I've just obviously explained to you. Total cholesterol minus LDL minus HDL equals remnant cholesterol, and there's not a lot of remnant particles in an LDL. So as long as you are getting healthier, as long as your glycemia is improving and your oxidative stress is very likely improving, then there's less chance that you're glycating and oxidizing that LDL, which is where the major risk comes from. And if your total cholesterol is going down and your non-HDL is going down, then that is probably a good thing. There is a separate paper that's just been released in the last week, which I can share with the group, which is showing that actually it doesn't matter if your LDL goes up a bit, as long as your total ApoB is going down.
Scott, the meta-analysis showed an increase in your total cholesterol and an increase in the LDL cholesterol. That was a meta-analysis which I think completed in 2019, published in 2020.
Yeah, I think is that the one I'm talking about, Gary? The one that's just been released in JACC? I can forward you the paper.
No, this was no, I don't think so. This came out in November rather than this year. So
well, if your total cholesterol goes up and your LDL goes up, that is bad.
But I take your point that HDL has clearly shown from multiple studies that it goes up with a low carb diet. But as you say, raising HDL has never been shown to actually lead to cardiovascular benefits in intervention studies. So I think that's actually quite interesting. I don't know the effect of all of this on whether or not it's good or bad. Do you have a view as to whether or not the impact on the lipid profile is bad with a low carb diet, or should we be thinking of giving people statins if they do go onto a low carb diet?
I wouldn't say give people statins if they're getting healthier. If their HbA1c is going down, you know, giving statins can give people diabetes in 10% of the cases. So if you're going to tip them over the edge from their liver insulin resistance by giving them a statin, I wouldn't do that if they're getting healthier and themselves losing weight. being more, having, better quality of life, HbA1c going down, HDL going up.
I find it really difficult, to be honest. So this
It
week,
is difficult. It is. It's not easy.
So this week being Thursday, I guess I've had 3 patients who are on low carb diets who have had dyslipidemia. The latest one being this morning with a cholesterol of 10. And you kind of think there is actually a genetic predisposition to people who will hyper respond to saturated fat diets. And I can't predict them, I can't identify them, but their lipid profile absolutely goes crazy when you tickle them with a little bit of saturated fat. We can't identify these people, but I worry about the long-term impact on cardiovascular risk in that subgroup of people on low-carb diets.
Have you got the ability to measure, ApoE genotypes in those people? Because it may be that they are 4/4 ApoE genotypes.
But they've got a type 3 hyperlipidemia. We don't. They don't have a particular rise in their triglycerides. They don't have an isomolar rise in triglycerides, which I guess is what you'd expect in a type 3. So not sure if it's that.
The other thing is, what are they doing with their diet? Because I've had a few people in a similar case, and what they've been doing is increasing a lot of saturated fat in the diet. In actual fact, they get a big benefit if you switch them on to omega-3 sources and more monounsaturated sources, and find out what it is they're chugging that's making it go through the roof. The other thing is, are they actually exercising or not? I've had a few people through the clinic who are stick thin and trail runners, so they are constantly running, and they don't have a very large amount of subcutaneous fat. And what I'd say is that their cholesterol is a bit like an adipocyte on the go. So the reason why they are tracking so much lipid around their system is because that's what they're fueling their body on. And if you imagine someone in the other status, so sitting on the sofa, obese, and able to store fat very well, not doing anything, a lot of their lipids have been sucked up and not spilling back out from subcutaneous fat into the bloodstream as non-esterified fatty acids. So I think you need to get a history from those people as to what they're doing as well. I've had quite a few of them in the CT scanner, and all of them so far have had a calcium score of 0. One guy had a cholesterol of 12. His LDL was 7. His dad had those metrics, and he had a test that showed he didn't have FH. And his dad is 85 now, and I know this is anecdotes, but his dad has clear coronary arteries, despite a life of a cholesterol at that level. So I think, Gary, black swans exist, and if the person is not metabolically damaged or not appearing to appear metabolically damaged in other parameters, then I think it is a very difficult call. And I appreciate your difficulties there as someone who's seeing these people come in and having to, give them a treatment. You feel compelled to sort it out given the prior evidence. Not easy.
Great. Scott, what do you think about the false reassurance that low HbA1cs for patients who are really centrally obese? That's a great question Kathy's asked.
Yeah, I see that all the time. So when you're hyperinsulinemic, you will, if you're getting to that point where you're not coping from the point of view of insulin being able to reduce your blood sugar effectively, then your blood sugar will spike after foods. But then after that food, as the insulin is present in the system, you tend to get a rebound hypo down to maybe 3.5, 4.5, and that's where hunger potentially gets stimulated. But also, if you spend 5 times a day at 12, and then you spend 6 or 7 times a day at 4, the mean of that is probably about 6, which would mean that your HbA1c will always come out in the mid zone. It is by definition a regression to the mean test. So if it's 40, if it's 41, 42, and the patient looks like they're diabetic, I think they probably are diabetic. I mean, if people are genuinely looking after the sugar and the starch that goes in, their HbA1c will be in the high 20s, early 30s. And I think there is a balance to be had somewhere. But yes, HbA1c can give you false reassurance. Definitely.
Great, thanks. And thanks everyone who's putting interesting things in the chat there. I think, gosh, we've run over, but I think that's been a really interesting discussion, particularly between the two rather higher flying members, no disrespect to my...
I'll send. I mean, Gary's not wrong. I mean, what do you do with people with cholesterols of 12 and stuff? I think you just got to make sure they don't have FH, and then really look into their diet and exercise habits. I'll send that paper that's just come out in JACC recently about lipids, and I'll try and send the one about HbA1c being a pretty bad marker of diabetes.
Presumably though, sorry, for people with FH, are we better recommending, I presume you don't want to recommend a high carbohydrate diet to them either, but you might want to suggest more protein, less fat?
I think the FH thing is difficult, because the guy I showed you, Northgard, he did the pertinent trial proving that in FH, you know, if you give statins as everything comes down, you improve outcomes, but it wasn't a randomized controlled trial. It was, you know, you give statins early and you see the benefit on the curve. There is a thing called Montreal FH score, if anyone wants to look that up. So for people with FH, a lot of what is driving their ultimate risk is the other factors. So their diet, their smoking, the whole package, and FH is a separate thing that has to be dealt with by, you know, lipidologists in a lipid clinic. I'm not a lipidologist. I'm a cardiologist with an interest in lipids. So I would say that, you know, there are techniques and drugs and things coming through for that should be utilized, and then they should be cascade screened, those people, because there's a chance to intervene early in their offsprings because of the inheritance patterns of that. So I think it's vitally important that you segregate out a potential FH from someone who's just metabolically damaged, and that would be separated out by addressing the lifestyle, because if the lipids come down after the lifestyle change, it ain't FH.
Brilliant. So I should have said this at the beginning, but I've said it before. We are recording this session, so and it will be available for viewing via a private link afterwards for colleagues that haven't been able to attend. So if you wanted to be blanked out from any of this, then please do send me an email, and I'll blank you out. Can I just share my screen and show you what we've got coming in future sessions? Oh, hang on. Okay, can you all see Kaiser there? I think he's here actually. So just to let you know, this is for next session, Dr. Kaiser Singh Sadra, who's a GP in a busy practice in Slough, who's got a rather large community of South Asians with a high prevalence of type 2 diabetes. He's been using the low carbohydrate approach for a big number of years now, much longer than Gail and I think, and it has been getting some amazing results in his patients. And then delighted to say that Dr. David Cavan, who's a consultant endocrinologist, has agreed to join us in May. So Kay's in April, and then David's in May.
Can I say something about Kesa?
Yeah, go.
Kesa was doing low carb when David Unwin was still eating Mars bars and falling asleep on his GP sofa. So, and I'm sure David Unwin won't mind me saying that. But Kesa knows what he's doing. He should be listened to. Absolutely,
he is the original low carb GP, actually.
Yeah, yeah.
So yeah, no, we're really pleased to have them coming actually, because we've had a number of people who have, with the sign up forms, they've said, could you help us out with our South Asian population? Because obviously the diet's rather a different ballgame, isn't it? So great to know how Kayser's smashing it so well in Slough. And then so the reason for getting David Cavan along is because we're those of us who are using the low carb approach for type 2s have noticed actually this works really well in patients with type 1 as well, and they also deserve good blood sugar control. And indeed, lots of patients are just getting on and doing it anyway, so it makes sense for us to be equipped to be able to help them. So David is going to come along for a session to help to hold our hands a little bit on that, because it's potentially a little bit daunting. And then while we're also on type 1, Ian Lake, who's on the call, he's a GP with type 1 diabetes who's really trying to help people, professionals and patients and parents, to adopt a low carbohydrate lifestyle. And he's got a really good website, Type 1 Keto. And Ian has arranged a couple of training sessions. There's one coming up on the 8th of April in the evening, and that's being hosted by Simon Wade on Webinars for GPs. And then he's got another one on Saturday the 10th, and that's a whole morning session, which is going to be, again, helping us work out how to help our patients with type 1 who want to go down this route. And then very quickly, I've shown this slide before, and we bang the drum for the PhD every time, just because it's an amazing resource for anyone that wants support. There's all these ambassadors that I've mentioned before. So if you want to look up to see if there's an ambassador near you, they might be really keen to help you run a remission group in your area. And I've highlighted the conferences. So Sam Felton, the director's just announced the this year's conference, which is going to be virtual again and completely free on YouTube. And so that's on the 8th and 9th of May. I haven't heard who the speakers are yet, but last year, what a lineup. There's David Unwin, Campbell Murdoch, some very interesting high-flying people on there. I think, Scott, you've done it once before, haven't you, as well?
Yeah, a few years ago, yeah.
So yes, we're really looking forward to that one. So I'm going to stop sharing. And I think that's it. So I'll send out the invites to the next one. The next one is actually a week later, because April's a bit odd and school holidays and stuff, but I'll send you the invites out nearer the time.
Thanks so much, Scott.
Yeah,
thanks again.
Thank you so much. That's been incredibly helpful to so many people. We really, really appreciate it.
Okay, bye.
Take care.
Thank you. Bye.
Thank you.
Thank you.